Hi, David. We're live.
Great. Good afternoon, everyone. Welcome, members of the HPC Advisory Council and members of the public, to the first virtual public advisory council meeting of the Massachusetts Health Policy Commission. From everyone here at the HPC, we hope that you and your loved ones are well and healthy during this time. It's great, really great to see you all. For members of the public and market stakeholders who are watching this meeting on our live YouTube channel, thank you for your ongoing engagement and interest in the work of the HPC. You may find the slide presentation that we will review this afternoon available on our website, and there should be a link in the YouTube channel video description online as well. Additionally, we really encourage you to follow us on Twitter at @mass_HPC for all the latest news from the HPC. We really hope to stay connected to you in this new virtual world. So for those of you who are on Zoom or watching online who may not be familiar with the HPC Advisory Council, this first slide in the deck details the current membership, which consists of a diverse group of healthcare leaders, over 30 leaders. I think we have a vast majority of the membership here today joining us via Zoom. Thank you all for being able to attend today and to participate in this first meeting. The goal of the HPC's Advisory Council is to enhance our robust policy discussions by allowing for varied and representative perspectives on the issues facing the Massachusetts healthcare market. The Advisory Council really serves as an opportunity for open dialogue and engagement with, as I said, a diverse group of healthcare leaders and stakeholders, and in turn, you really help inform the work and priorities of the Health Policy Commission. As this is the first meeting since the COVID-19 pandemic struck Massachusetts and the world, today we plan to provide a brief update on the HPC's operations and recent work and publications. We'll then turn to a discussion on the impact of COVID-19 on the healthcare system, financing, delivery, and payment models, with a very brief presentation of some of the latest data and research that we've been compiling. Following this presentation, and really the bulk of today's meeting, we really want to seek your input, Advisory Council members, and feedback and expert guidance on two particular topics. One, the development of a health equity lens for the HPC and the HPC's work. And two, the HPC's revised work priorities for the rest of the year in light of the pandemic and its historic disruption to the healthcare system. As always, we want this to be interactive and ask that you share all of your perspectives and ideas today. That is really the purpose of these meetings. Advisory Council members, we have you all on mute in the Zoom and just ask that you use the hands up function. And we'll make sure to call on you so that you can have an opportunity to contribute. And as we call on you, please just introduce yourself at the beginning and your organization. We're not going to do a round robin introductions today. I would also note at the top just a disclaimer of the two big agenda items, the health equity lens and the work priorities for the rest of the calendar year. These have not been finalized. These are still in development and have not been finalized by the HPC's board yet, and therefore are subject to change. We really hope to solicit your input and incorporate your input before presenting a final version to the board 1 week from today. We have a board meeting next Wednesday where we would plan to present these agenda items again to the board. So thank you for providing that input now at this development stage, and we're excited to be able to preview some of this work with you. Speaking of the HPC's board, I'd like to recognize Dr. Stuart Altman and Dr. John Kreider, who are joining us here today to listen in and to help participate in today's meeting. So Stuart, I don't know if you want to say a few words at the top here.
Well, just I'd like to say hello. For some of you, these are we've known each other for a while. I haven't been part of this advisory group for probably a year or so. So I will stay mute and listen. Occasionally, I might chime in just to make sure that I'm alive. But other than that, I look forward to the discussion, and I think we're in very complicated times, but I'm optimistic that we'll figure it all out. So thank you, David, and I will look forward to the discussion.
Thank you, Stuart. And as always, you don't need to raise your hand. You can always just chime in whenever you want. Board chair prerogative. So with that as just a brief introduction, I do want to just thank again all of the advisory council members for taking the time today to be a part of this meeting. This really is such an important group and such an important forum for these types of conversations. And I know I've mentioned this in the past, but truly, as I have had the opportunity to talk to different states, this is really a unique body across the country to have such leadership in so many different areas, being able to come together and even spend an hour and a half having these types of conversations is quite special. So I think it's a reflection of our Massachusetts ecosystem, and one that has been reflected in how everyone on this Zoom call has really come together and supported each other and supported the people of the Commonwealth throughout this pandemic. So thank you for everything that you do and your organizations do. It has been truly meaningful to get us to the stage that we are at today. And we'll talk a little bit more about that. But first, just to give a brief update on our operations from the HPC and some recent updates, I'm going to turn it over to our Deputy Executive Director of the Health Policy Commission, Colleen. Take it away, Colleen.
Thank you. Thanks so much, David. Welcome, everyone. Good to see you all. Yes, David just asked me to give a quick update on agency operations. Like many of you, our Boston offices have been closed for the past 4 months. The HPC is fully remote. We are very much open for business, very grateful that all of our staff can work safely and remotely from home. So in addition to working on COVID response efforts, our ongoing work streams, research projects, and publications continue apace as before. I wanted to highlight on this slide a very important part of our agency. The HPC's Office of Patient Protection, or OPP, is also open for business. OPP is operating very smoothly, assisting patients and protecting the rights of healthcare consumers by processing external reviews, redirecting consumers who need access to health insurance, and answering calls on our hotline. Before I move on, also just want to pause on this last bullet. As many of you know, the HPC has been supporting the Commonwealth's efforts to combat COVID-19, and there was a big immediate response, and now we're engaged in ongoing activities to support the reopening and continued vigilance efforts on behalf of the Commonwealth. So on behalf of the agency, of the HPC, we just wanted to share our gratitude and our appreciation for the Secretary Sutters, and her work in the COVID Command Center. As you all know, being on the front lines yourselves, the response in Massachusetts has been all hands on deck situation. Without the leadership of the Secretary and the Governor and the Command Center and so many others on this call, we would not be in the position we are in today. So for the HPC's part, our small part, we've prioritized the COVID response work that we have been asked to do. Whatever we can do to assist, we are here to help. Specifically, we've been leveraging our expertise and fluency with the healthcare system, with our data assets, our research expertise, our investment experience, our market knowledge to support the response. So this is a top priority. Just wanted to say at the top, we've made this a top priority, and we did whatever we could whenever we were asked. So as everyone did on this call, to be part of the solution. So thank you all. On the next slide, there's a lot of information here, But in leading up to giving you all a high-level update on what we're planning for the cost trends hearings this year, I just wanted to quickly touch on the new timelines for data reporting to our sister agency, the Center for Health Information Analysis, CHIA, the state's healthcare data collection agency, the Data Hub. So due to COVID, we've had to adjust a lot of our timelines with regard to the benchmark, and we've done this in partnership with CHIA. In fact, this adjustment was previously under discussion by our board and our staff, even before COVID, to accelerate our ability to hold entities accountable through the PIPS process. As you all know, just a reminder, the benchmark statewide target for the rate of growth of total healthcare expenditures, THCE. The most important thing to know about the benchmark accountability timeline adjustments here is that the collection of TME data, total medical expenses, the data by which we measure the state's progress against the benchmark, has been shifted to the fall from the spring. So it's important to note that with this shift, in the first year, this will include final data for 2 years. And then on the bottom half of this slide, would just note that with these updates, the plan is for CHIA's report on healthcare spending to be released in January. And then our annual hearing on the benchmark will be held in March. So as I said, this timeline adjustment also has implications for pushing back our performance improvement plan process as we shift data for 2 years. So as a result, and this is ultimately a really good thing moving forward and something we've really pushed for and wanted to do, but we're not going to have data on our performance on the benchmark in the fall. So we plan to therefore focus on the benchmark in the spring after the CHIA report comes out. So on the next slide, so what does this mean for the 8th annual healthcare cost trends hearing, the Super Bowl of healthcare, which I know you all look forward to with either excitement or trepidation or both. But this hearing is focused on performance under the benchmark and all the drivers of healthcare costs therein. So we're proposing at this time to reconceive the hearing for the fall. We are planning to hold an event this fall, but instead with a focus specifically on COVID, to be specific on the impacts of COVID and all the aspects of the healthcare system. So we think this is a great opportunity to have a conversation with you all on the impacts of the pandemic. And we invite you all as our advisory council to be a part of it, whether you're called to participate or not. So it's important. We want to continue this tradition, but with a new hearing and a new format and a new virtual forum. So understanding there may be another event in the spring specific to benchmark performance, this is going to be our proposal that we're bringing to the board of the Health Policy Commission next week. We have a virtual board meeting next Wednesday at noon. So little bit of housekeeping before I close out. We know that everyone is going to want to know, are you going to be called to testify? Are you going to be preparing written pre-filed testimony this August? I don't have answers to that today, but before we bring the proposal to the board, just wanted to give the heads up first to you all that we're not expecting to do the 2 full days like we normally do. It will be different, and we will issue an update soon on all aspects of the hearing, so everyone is in the loop on that. So if folks have comments and input, which we absolutely welcome, please just hold to the open swim. We just want to jump right into the data after David gives one more quick update on what to expect for upcoming publications. But look forward to comments and input on everything I presented on, and thank you all. Turning it back to you, David.
Great. Thank you, Colleen. And, I think the cost trends hearings will be different this year, but I do think, as Colleen said, it feels like a really ripe opportunity for some reflection, but also future planning and to really think about how we build resiliency in our healthcare system, how we accelerate and sustain the positive changes that we've seen in areas such as telehealth, and how do we mitigate some potential negative consequences moving forward. So feels like a good time and opportunity, and we hope that the case numbers here in Massachusetts continue to be something that will support having that forum and having that time for conversation. Really quickly, just one slide on new and upcoming publications. We have been continuously putting out new work throughout the COVID-19 crisis. The 3 stars here indicate the 3 new pieces of work that are available on our website. So first, We did release our study of the impact of drug coupons in Massachusetts. That was released, I think, last week and is available on our website. We also released recent data points on trends in the physician market in Massachusetts, where we examined changes in affiliations among physicians using data from our registration of provider organization data. And then on the upper right, we also posted to our website new profiles of all of our awardees through the Shift Care investment program. And the Shift Care investment program is focused on two tracks. One is awardees focused on addressing health-related social needs. And the second track is around increasing access to behavioral health care with a sub-focus on initiation of medication-assisted treatment in the emergency department for patients with opioid use disorder. You can see three other publications here that are not starred. These are upcoming publications, and we plan to be able to post those and release those in the next coming weeks. So we'll have a playbook on lessons learned from the CHART investment program. We're going to have an update on a report that we did a few years ago called Community Hospitals at a Crossroads. And so we have many more years of data. So we're going to update many of the analyses that were part of that initial report with recent data. And then finally, we have a brief that we'll be releasing soon, summarizing the performance improvement plan process and the reflections and impact of that process over the last 5 years. As always, we publicize the release of these publications on our Twitter account, as well as through our HPC Info newsletter. So if you are not a member of the HPC Info newsletter listserv, please go to our website or just email one of us, and we'll make sure that you get those regular updates. So with all of that housekeeping taken care of, we now really want to turn to the conversation with you all. And really the focus of today's conversation is going to be around how we examine the impact of the COVID-19 on our healthcare system and how the HPC should align its work to meet this challenge for the rest of this calendar year and beyond. Additionally, we will preview for you work that we are doing, pursuing to create a health equity framework, which will guide not only our work in examining the impact of COVID-19, but really is intended to be a framework that we would apply to all of our work at the Health Policy Commission moving forward, and really want to be explicit about how we are examining health equity principles in every aspect of our policies, programs, and operations. So first, I'm going to ask our research director, David Auerbach, to present just a few summary slides about what we understand about the impact of COVID-19 so far. I would note at the top that while much of this data is, some of this data is through June, mid-June. Obviously, there is data lags, and we know that the impacts of the pandemic on the healthcare system was most acute in April and in May. So there is some data lag issues that we are continuing to struggle with. But David's just going to give just a brief summary of the research that we've been tracking and following, and this is compiled from literally hundreds of different sources that we've been monitoring on a daily basis. And after David walks through these slides, we're going to pause our part of the conversation and open it up for a conversation, because you all have been on the front lines of this crisis from the very beginning. And we really want to hear from you about what your experience has been, your reactions and reflections on the data that we're going to be presenting, as well as your input and on where other areas of focus and research the HPC should have moving forward. David, I'm going to turn this over to you just to walk through some of these summary data slides about what we know so far.
Great. Thank you, David. Okay. And as David Selt said, this is just a few slides. There will be a more expansive presentation of this and other material at the board meeting that we'll be having in a week. That'll be open to the public. We wanted to review some of the brief highlights here. So this slide is a summary, and some of these points are expanded on some of the slides that are coming afterwards. Starting with the top bullet, this is reflecting now pretty solid data published by the Alterum Institute showing that healthcare spending, including all categories total across the US, dropped about 30% in April from what it was a year before. And when we project that to what it appears to be, including the recovery path throughout the rest of 2020, although this is incredibly uncertain, of course. But it looks like on average for the year 2020, healthcare spending is looking to be down and roughly on the order of about 10% in total. Going to Massachusetts, from the hospital point of view, this is a new publication by Chia, and we'll show this in a couple slides. Most hospitals had negative margins in the first quarter of 2020. And note that is the first quarter only through the end of March. So not even including the height of the lockdown in April and May. And those are median margins. I'll show that in a minute. Third bullet, healthcare spending dropped faster than the overall economy. So that 30% is pretty significant compared to about a 14% drop in total GDP. But note that healthcare employment also dropped, but slower than the rest of the economy, only by about 6%. And I say only, but that contrast suggesting that people who employ healthcare workers tend to be holding on to those workers and assuming that a lot of this spending drop is going to be temporary. Now we have some data from, as we've shown before, from a somewhat informal survey of providers in Massachusetts about their plans and their experiences with the pandemic in the past month or two. One finding from that survey that I'm highlighting here is that independent primary care practices are much more likely to say that without a major change, they are likely to close. And that's a roughly 10% magnitude there. Some other trends that we're noting in the data, and others are finding, that pediatric visits remain quite below expected baseline, even up through mid-June, 30-ish% below expectation, whereas adult visits are returning towards normal. And we have noted in previous presentations the huge rise in telehealth visits. And those seem to have now come back down from their peak in April. We've been tracking that pretty carefully to see what's going to happen with telehealth as in-person visits resume. So they have declined. And for a lot of conditions, there is still variation by condition, and we'll show a slide on this. A lot of conditions, visits in total have gotten fairly close to pre-baseline levels, or even more when you include telehealth. Okay, so a little more detail in the next several slides, just expanding on some of the points I made earlier. This is showing that 30% drop in overall healthcare spending in the second bar. You see it's more than GDP. And then by category of service, there is quite a lot of variation, as to be expected. Hospital, physician care, spending was down around 40%. Dental was down 60%. But then some other categories of care, such as prescription drugs, nursing home care, did not decline over this period at all. This is a little more detail on the bullet about hospital margins. Here you can see, I know this scale is very small, but these are the past 3 quarters. So the second 2 quarters of 2019, and then you see that drop in the first quarter of 2020. These are the median margins by hospital cohort. So that green dot is, for example, community hospitals, and each tick on that y-axis is 1%. So that's about 3.5% negative margin median among all the hospitals that are community hospitals, for example. but all hospital cohorts are negative at the median. That doesn't mean that every single hospital had a negative margin. Some were positive, but the typical hospital, the average hospital within those groups did swing negative. And I imagine for Q2 2020, it'll be even more so. Okay. And here we're showing a little more detail on visits by category of care. And I'm sorry about the abbreviations there in sort of medical speak, but you can see, for example, interestingly, so the blue bars are the number of telehealth visits, where the green is in person in office. And the double bar for each specialty is just showing the week ending June 5th and then the week ending June 12th. And a lot of those are up over 100%, visits for ADHD or depression, for example, with the huge contribution of telehealth to those. And then a number of other categories of visits. You can see hypertension is HTN, type 2 diabetes are approaching, when you include telehealth, are approaching expected or baseline levels, even in some of the specialty categories to the right. Okay, I believe that's what we're going to show on this today. I'm sure there's lots of variation, and most of those are national data, but for the most part, we're seeing a lot of the same trends in Massachusetts when we have data for both. Okay, thanks, David.
Great, thank you, David. And I think that last slide is really interesting for me to see the importance of telehealth in being able to contribute to the return of some of these services, especially in those first two categories, ADHD and depression, migraine. You can see that there's a significant amount that is being provided through telehealth. So telehealth continues to be a really critical tool as we continue even in a more stable phase, a reopen phase of the healthcare system. So I'm gonna pause here and would love to get some feedback, reactions, questions just on these data slides and from anyone on the advisory council. So Colleen, I don't know if you're gonna help.
Sure, David, we have Colin's gonna kick us off. Thanks, Colin. You're just on mute, Colin.
Right, there we are. Sorry, I think we were trying to mute and unmute at the same time. But so I was just wondering, thank you, David, for these slides. I was wondering about the impact of profitability with regard to sort of excess capacity and redundancy. I know that one concern in the early part of the pandemic was hospitals, not having excesses of things like ventilators on hand because of, in part, for profitability concerns, right? That slack capacity leads to hospitals being less profitable, but slack capacity is what you need when there's a surge in the pandemic. So we'd love to hear about the impact of that and about whether the HPC is considering adjusting some of its calculations going forward to account for the fact that hospitals will probably need to maintain some amount of slack capacity in anticipation of a second wave.
Thank you, Colin. David, I don't know if you have any immediate reactions to the concept of the slack capacity. I can probably speak to the second part of the question, which is how we take some of these things into account.
Sure. Yeah. I mean, we're tracking the data, the spending, the occupancy rates as they are, and that's probably something we would be able to get a little more detail on to the extent that you're interested. And we haven't tried to piece apart, margins or hospital spending as to the contribution and how much being required to maintain slack capacity might contribute to that. It's certainly important. So yeah, just back to David.
Yeah, I would say one of the areas that we are proposing for ongoing HPC work this year, Colin, is in the areas of kind of health planning and capacity planning to try to better understand, do we have the resources we need in the places that we need? And I know the administration is actively thinking about that every day with regard to planning for a potential resurgence. But I think the question raises to me an even bigger question, which is to say, how is the cost structure of hospitals and other providers going to change as a result of needing to continuously be prepared for resurgences. That may be obviously a cost additive to any healthcare provider structure, but there may be other places where we see some efficiencies and potential changes in the way care delivered that may go in the opposite direction. So I think, parsing through those different dynamics is something that we are proposing to really dedicate some time on this year. I don't know if we have a couple of hospital leaders on the phone here and on the advisory council. I wonder if I could ask Christine to chime in, or Steve, if you have your own perspectives on what your experience has been in managing and planning and thinking about having that capacity when we need it. Because I would say on a general broad picture standpoint, the hospitals in Massachusetts really stepped up in terms of their ability to create surge capacity, to be creative in space planning, be creative in using technology and ventilators in new ways, and just a lot of incredible innovation, but also a lot of really hard work that goes into that. So I wonder if I can call on some of our hospital colleagues to maybe add a perspective to this part of the conversation.
Sure, I'm happy. This is Chris Schuster. It's great to see everyone. First, I'll say having Steve Walsh at the helm of Mass Health and Hospital is phenomenal, because I don't think in my 23 years of being a CEO, I've ever seen everyone really coming together and working very well, multiple calls, many days a week, a lot of data sharing. The walls really came down, and that was very helpful. Early on in the crisis, it was very difficult for hospitals because the PPE supply chain lines weren't firmed up. And so we were all a little bit panicked, but by about 4 to 6 weeks into it, for the most part, people got settled with that. But we were all given these sort of projections about how much volume we could expect. And it depended really on what type of hospital you had. If you were in a region like a city, a Brockton, a Boston, a Lawrence, a Lowell, you were much busier than if you were like me, a community hospital in the suburbs, which really isn't as dense. And so there was wide variations throughout the state in how busy different places were. For example, in my hospital, we stood up a second ICU, bought 32 vents, and never really saw a tremendous amount of volume materialize. We ended up with 165 COVID patients over the surge, and had quite an investment in preparing ourselves for what was coming. I have to say, if there's anything that HPC can help us with, it's telehealth, and I love having the volume slides. If insurers will reimburse us for this moving forward, that will be critical. And I do think that if we could hold the gains on telehealth, that's going to really help our system, because we can take better care of patients who have a harder time getting out, don't have to come to the hospital, and can be managed through a telehealth visit. So if that's one area we can hold the gains on the innovation. I know at my hospital, we've been trying for 2 years to get telehealth to stick. And all of a sudden, within 3 weeks, we had like monumental gains, because that was the only thing that we can do. So that was really, really important. We all worry about the second surge. And I think personally, we're going to have to learn to coexist with this virus. I think shutting hospitals down again is going to be a big mistake, because we can't sustain another 65-day shutdown of no elective procedures at all. We've learned how to keep people safe. We have testing capabilities. There are a lot of additional costs right now to running a hospital, implementing all the guidelines, which are very important, but it's additional PPE, it's additional staff to implement all the guidelines. And many of our volumes in certain areas, because of the social distancing, you can only see about half the number of patients you normally could be because of the way you have to clean in cardiac rehab, because of the number of people you can have per square foot. So it's really limited our ability to work at maximal capacity. So I do think it's going to be challenging for hospitals, especially community hospitals where we tend to make our business and do well on elective cases, which are the ones that were stopped, for quite a while. And we don't have we're not a trauma center. We don't see the sickest of the sick, and that's where the in-town hospitals tended to do a little bit better. So that's what I have to share.
Thank you, Chris. And we presented some data at the last board meeting that highlighted what we thought was actually a slightly disparate impact on community hospitals because of the reliance on outpatient revenue, even though maybe not as hard hit with COVID patients, but the revenue impacts are significant. And generally, community hospitals just have less strong financial footing, kind of even going into the pandemic. So that is something that we're absolutely watching. One quick note on the telehealth piece. It occurs to me that telehealth is also an important strategy for maintaining PPE supply. The more that we can do on telehealth, the less that we have to have an in-person visit and use that PPE. So that will be important as we think about a potential resurgence. So Colleen.
Sure. David, we have Steve Walsh and then Dr. Wagner and then John Hurst on deck.
Steve.
Thank you, David. Good to see you, Stuart. Good to see you back. Nice job at the last meeting. First of all, to your team, David, thanks for everything you've done. Your team has been incredible over the last 5 months in dealing with this crisis, from your leadership level at the board all the way down to your team and the staff that you surround yourself with, and certainly you as well. Chris, thanks for the kind words. All the credit here really goes to our healthcare providers who have been nothing short of miraculous throughout the last 5 months. And I want to answer that capacity question, mention money for just a second, and then close on telemedicine. The collaboration that we've seen in this state has been simply extraordinary. And you didn't see that in other parts of the country, which is why I think you saw some of the challenges as the virus moved into Washington State and then into California, through New York and New Jersey, and through Massachusetts. But I think it's also important to remember, we're not through this yet. We're still in COVID-1. We're still in the first wave of COVID, and will be for some time as we continue simultaneously to plan for what is a likely resurgence in the fall. So these are very scary times. On the slack capacity question, so on March 18th, as you're well aware, in partnership with the administration and leadership of Governor Baker, all hospitals shut down scheduled events, elective procedures, and any type of routine visits whatsoever. We have 14,500 hospital beds in the Commonwealth, and we needed to fill as much possible capacity as we could to make sure that we were ready for a surge that ended up coming in April and peaking around April 19th to the 20th. We thought we would need 30,000 hospital beds at the height. So we built an additional 9,000 hospital beds throughout the Commonwealth in 6 sites that were outside of the walls of the hospital, in tents in field hospitals, and with utilizing every available unit within existing hospital facilities. It's important to remember that we had the 3rd most cases up until about a week ago in the country. And so the reason why you didn't see the type of challenges you saw in other states is because of this partnership and collaboration among providers, because of hospitals' willingness to give up any additional revenue through elective or scheduled services to make sure that they put the health of the public first. Now, we didn't need all those beds, but it is much more important to have them and not need them We hoped that if we built it, they would not come. And in many cases, some of the field hospitals saw capacity and some did not, but we were prepared throughout. So when Chris talks about her challenges, it's very true. And her financial challenges are going to be real because of the choices that she made. But she made the choice so that she was ready to serve her community should she need to. Now, in terms of slack capacity moving forward, as David knows, as you structured this with members of our team and members of the administration, there's still a 20% holdback in terms of capacity so that we are available should a surge happen. So there are available beds right now through ICU and med-surg in every hospital throughout the Commonwealth as part of the condition of moving into phase 2 and phase 3 of our continuing to evolve into more services in the hopes that we will not see any capacity challenges. And because the governor and Secretary Sutters and their team are looking at 3, 5, and 7-day rolling averages, we would be able to move patients out of the hospital very quickly and get ready for incoming COVID patients should we need more than that 20% that we have available. Moving to money just for a moment, and I think you've all heard me talk about it, so I won't belabor it too much, and I appreciate the updated data by the HPC. We are looking at Q2 now, which I know you've already mentioned and David has mentioned, David Auerbach, that is that there is a lag time in some of the data. But in terms of the survey responses to EHHS on Q2 data, the hospital operating margins have declined 58% Q2 on average, 40% in the aggregate. Of the 52 responses, 51 lost significant money, all the way from 1% to 241% in the margin. And only one hospital in the Commonwealth, the small critical access provider, had a 1% margin. So Q2 is going to be catastrophic for Massachusetts hospitals. And in Q3, if we see a resurgence, this is going to make it even more difficult for our hospitals to meet the demands moving forward. And this is not a time that our healthcare providers should be worried about finances from the hospital level all the way down to physician offices. And the last piece I'll finish on is where you finished on telemedicine. Excellent point on PPE. The biggest gift we can give our frontline workers in the preservation of personal protective equipment is access to telemedicine. Keeping folks out of the hospital before they get there is the most critical piece that we can do. And in March, before telemedicine was taking a stronghold as it did in April, we had a 50% decline in ED visits. We had a 65% decline in patients with symptoms of stroke, a 37% decline in patients with heart attacks, and a 14% decline in appendicitis. Percentages don't change like that. Dr. Altman knows this and others that have been doing this for many, many years. That means that really sick people were staying home and didn't have access to their healthcare provider because they were afraid of COVID. We can't let that happen again. As we kind of reopened and re-added services moving into May and June and July, the folks that are presenting at the hospital, and Dr. Wagner can certainly speak to this better than I can, are very, very sick. In many cases, they're leapfrogging right over med-surg and they're entering the ICU because they were staying out of the hospital through the surge of COVID. And that's something we need to make sure that we are very careful on in terms of our response to public health. So David, thank you for everything you and your team have doing. You have been incredible partners, as has Governor Baker and Secretary Sutters, and our healthcare providers, as I said when I opened, I think have been simply miraculous throughout this entire effort.
Thank you, Steve. Okay, good transition to Dr. Wagner, and then on deck, John Hurst, Jim Hunt, and Bonnie Gilbert.
Great, thank you. And I'm so grateful that Christine and Steve went before me because my comments will just be brief. So just to bring us back to April 20th or so when we were at our surge, the COVID patients were only still 40% of our overall census for our organization, but our census was down pretty considerably. So just to remind everybody that the patients who didn't have COVID still were receiving care and needed to get care. Steve's point around patients who were foregoing care, we're now seeing the consequences of that in delayed diagnoses and in outcomes that are worse than they would have been if we were at full tilt. As the lesson from that is that as we go through this next phase where we will see an increase in cases, and how that exactly will play out is yet to be seen. We've got to figure out how we can thread the needle of ensuring that patients with non-COVID illness can be cared for while we're taking care of patients who have COVID as well, and maybe even flu. So I think that's an important piece of work that needs to be done in planning for the next increase in cases or the next surge. I would agree with the comments made on telemedicine. I do believe the cost structure on telemedicine is going to need to be figured out. I think there are some fixes put into place that accelerated. We put over 1,000 providers in a 5-day period on telemedicine and moved dramatically to move a large number of our visits to telehealth. And solutions were created to encourage that through, reimbursement. Developing an appropriate cost structure or fee schedule for telemedicine will be important. It can't be as low as it was previously, and it's got to be structured in an appropriate way. I think the point, and I'm not going to belabor this because Steve covered it so eloquently, but this concept of having excess capacity ready at any time means that, to Colin's earlier question regarding, ventilators and excess expenses that we have incurred, the ongoing operating impact of having that excess capacity far outstrips the small amount of capital investments that we had to make. And we can't forget this, and it will have an impact in terms of the overall operating margin for our organizations, even beyond what we had to do in terms of canceling cases to get ready for the surge in March, April, and May. So I'll leave it at that, and I would thank Christine, Steve, and others for the comments that they made. They made my job much easier.
John Hurst.
Yes, thank you, Colleen. I just wanted to make a couple comments. I really appreciate the economic hazards that the healthcare industry has gone through over the last 4 months. I just think it's extremely important that we do not lose track of the fact of what the premium payers have also gone through. I look at our 4,000 members, fully 30% of them do not expect to survive this economic crisis. They were told by government they had to close their doors. They had to still pay their rent. They still had to pay their health insurance premiums. They still had to pay their suppliers. 80% of our members had sales reductions between 25% and 100% off of last year. And I just want to make sure that there is a real balance when we look at the dollars and make sure that those that are continuing to pay their premiums and oftentimes the double-digit premium increases are being treated fairly at this. I think that we need to make sure we have a full, transparent accounting of taxpayer dollars. We are all taxpayers, where those dollars went. I think we need to really also take a really close look at telehealth. Every other industry on the face of the planet, when you look at new technologies, that results in higher productivity, and that increase in productivity normally is intended to result in lower costs to your customers, not higher margins to the particular industry. And I just find it troubling that we're looking at the same reimbursements for telehealth that we would face to face, and that's something I think that has to be looked at and changed very, very soon. And finally, I would just say, look, if the spending is down 10%, when you look at small businesses and their highest premiums in the country, we got to look and see, well, how much of that 10% is going to result in lower premiums? Should we see 10% lower premiums? Should we, the MLRs, what we just that belongs to the premium payers, and we want to make sure it does accrue back to those small businesses who are also struggling, in many cases far worse. Thank you.
Thanks, John. And I would note a little bit later in the presentation when we will show some of our proposed work plans for the rest of this year, you'll see that we do intend and are considering a kind of a comprehensive analysis and evaluation of the impact that would not just be on kind of the healthcare providers, but also health plans, the premium payers, the employers, potential differential impacts by individual markets, self-insured, fully insured. We expect that we'll see some shifts in insurance coverage away from commercial to public plans and subsidized plans, given the economic disruption. What is the allocation of potential reduced spending in the form of rebates or payments to providers, as you said, or premium relief? So I think we are proposing to really think about this from all the different aspects and angles. And as you said, John, not lose sight of one of our core constituency, which is the residents of the Commonwealth who pay for healthcare. And so my commitment and our assurance is that we'll continue to evaluate affordability and the impact on residents and employers as we think about the impact of COVID, not just on the provider side, but on the health plan side as well. Colleen?
Yes, I have a bit of a queue here. So we're going to Jim Hunt first, then Bonnie Gilbert, Dr. Strongwater, and Colin. Jim?
Thanks, Colleen. I'll try to keep this very brief and somewhat echo what previous speakers have said, including Steve. Incredible effort by the hospitals, lots of coordination with us at the health centers. Clearly, we would be out of business without the assistance of both the state and federal governments and, in some cases, private philanthropy. When we presented our numbers after collaboration with Steve and with some of our national partners, we saw a 67% decline in net patient service revenue in the month of April. And basically, in some cases, full shutdowns of sites and services. Particularly hit dental practices at 80% decline in visits, and with lots of practices across the state closed for a certain period of time. So we're very thankful to the Commonwealth, particularly to Mass Health, for stepping up and aiding and abetting the health centers to, one, stay in business, and two, to pivot to what's been already discussed with telehealth, telephonic visiting, and outreach. But we've also seen a surge in not only Mass Health members. We were always at 50% Mass Health. Now we're hovering much higher than that, and more uninsured. So the campaign that we've launched in multimedia, cultural, radio, television, and elsewhere has been welcome back to your health center. You're welcome here. Make sure that your child gets their pediatric immunizations. Make sure that you contact your provider. You are welcome here, and we are open. And to some extent, that's true. And to some other extents, it's very difficult if you've got an old building, not some of our brand new health centers, but an old building where you have to retrofit your dental suite with no capital funds. Very little in the CARES Act around capital and retrofitting to meet patient needs and the demand of bringing back, if you will, a full cadre of services. Bringing back services at 20% makes the margin worse rather than better. And then we pivoted, unlike the hospitals that were seeing the surge in hospital capacity, we were seeing the surge in community responsiveness, particularly through a race and equity lens, which hasn't been mentioned yet. So in our communities, in the 23 gateway cities of where there are health centers serving over 1 million people in Massachusetts, there needed to be a real substantial pivot to look at COVID-19 testing as it related to communities, not just to patients served by health centers. So we engaged in the contact tracing efforts with Partners in Health, and thank you to the Command Center for pointing them our way, and with local communities, particularly public health entities, to try to coordinate those services. This, of course, puts a challenge on the workforce that you have, in fact, redeployed to do this work, and now you need that same work back in the health center to provide services both on a face-to-face and a telemedicine basis in order to get your patients served. So this community responsiveness that the health centers have taken on, and it varies from health center to health center across the state, I think has been critical to add to the body of knowledge of what's happening in communities and who's getting back into care. So lots of collaborations with on-the-ground community-based agencies, and certainly with our community hospitals and our academic medical centers that have been extremely responsive. In the issue of PPE, it's up and down. We've been helped by some organizations. We received, I believe, almost 1 million pieces of PPE from Direct Relief, the Kraft Center, and others, but was still not able to meet the full demand for PPE, particularly gowns and N95 masks. Our concern is the surge in need for flu vaccine in the fall, particularly if decisions are made to send children back to school, and the need to make sure that children get back into pediatric care, which was already mentioned by David Auerbach in his presentation, is of real concern. And then finally, and probably most importantly, among those services that you identified as being done with tele, we're having great success in BH and mental health services with tele. Many of my colleagues across the country are saying telehealth is here to stay, but as John and others have said, we need to find the right place for it and begin to enable patients, particularly those that are public recipients of care, to monitor themselves, to get into care, and to and basically use these services efficiently. So when I stop there, thanks.
Thanks so much, Jim. Okay, Bonnie, you're up next.
Thank you. So I really have more of a question than comments, but I do want to second John Hurst and David's comments about the payers for services, and that sort of goes to my question. I know we've been focused on the hospitals, but I just wanted to ask a couple of questions on the telehealth with mental health care services, and how closely we'll be looking at access to that care in terms of equity and economic access. You know, it's kind of interesting to see that services or visits rather are already back and above baseline. And I know that we are expecting a tremendous further increase in the need for mental health care services based on what's going on. And so I'm just really, I think we are really concerned, and I'm really curious to see how we're looking at the usage of telehealth and to make sure that that there is actually full access available to those in need on the mental health care side, and those issues surrounding that. Is that relatively clear in terms of what we are concerned about?
Yes, absolutely, Bonnie. And I would say one of the areas that we're proposing as part of our work plan for the rest of this year is to contribute to an evaluation of some of the policy changes that occurred during the COVID peak, and to be able to make recommendations about how we can kind of, as I said before, kind of sustain what's working, but also adapt and evolve these models to make sure that they're working for everyone. And we know that there are still, communities within the Commonwealth that don't have access to broadband internet, for example. And so I think part of that, and as you'll see a little bit later, across everything that we're going to be looking at in kind of the COVID impact evaluation and analysis, we need to embed deeply within that a health equity lens. And that's something that we're really thinking hard about and being explicit about as we think about how do we understand how these policy changes have impacted all different types of populations. And that's, I think, really critical that we take that intentional step at the outset. I will say, when it comes to evaluating telehealth, we obviously have been kind of tracking kind of the utilization numbers, and some of these are national numbers. In addition, we are exploring with other partners in this marketplace an opportunity to do some patient surveys, provider surveys, to try to understand better the kind of the satisfaction for different types of services. What did this work well for? Maybe some services it does not quite work as well for, or needs to be changed. So we're thinking about not just kind of looking at just the utilization data, but really trying to get the perspectives of both the providers and the patients about how they have interacted with this new technology. And we think that is really important voice to help us think about, again, kind of policy recommendations and the future of telehealth. And I would, we've talked a lot about telehealth already here today, and I just want to give a shout out to Dr. Kreider, who's an HPC board member, who's been a really vocal advocate and supporter for the HPC to really take a leadership role in examining this. And so thank you, Dr. Kreider, for your continued advocacy and support in this area, and something that we do intend to take on. So thank you, Bonnie. Your comments are well taken.
Thank you.
Good segue back to Dr. Strongwater, who I know had a comment on telehealth.
Oh my, thank you for the opportunity to talk. This may be a little bit of overkill. I'll just add, I really appreciated John Hurst's comments and Jim Hunt's. I don't know if everybody is aware that there is a cost to telehealth. We've spent nearly $1 million gearing up in training, in equipment, in process. And so early on with new technology, or although this is not really new, it's important that you front load the investment and reimburse at parity. That helps not only to cover those costs, but also it encourages people to use the technology. Otherwise, we'll revert back to where we were in the pre-telehealth sort of reimbursement mode. So I want to encourage HPC to dig deep into telehealth. I'm thrilled that you've identified it as an area for research, but I would just caution that if you roll back the reimbursements right now, it's going to be potentially catastrophic to a lot of ambulatory practices. The last thing I'll just mention briefly is PPE. I'm not sure if we're stockpiling, but boy, it feels like a good thing to me to get ready for. So thank you for the opportunity to talk.
Thanks so much. Okay, Colin Killick, and then David Mattiotto.
Thank you so much. Just to put a sort of one sentence button on the excess capacity point. Yes, I think it's a credit to Massachusetts hospitals that we didn't have rationing of care occur here, even though the crisis standards were put in place, they weren't used. We do know that in other states, people did die directly as a result of care rationing, including in ways that the Office of Civil Rights at HHS have found violated federal civil rights laws protecting people with disabilities. So I think it's critical that we plan for the future in ways that ensure that care won't be rationed in a future wave or indeed a future pandemic, and that we come up with a cost structure that allows hospitals to be able to do that. And then on the telehealth point, I think, yes, expansion telehealth is great. I've been making use of it myself. Just a minor point, and we're happy to be helpful with this, to be sure that that telehealth is fully accessible, including for instance, deaf people who often have difficulty making effective use of it.
Thank you, Colin. David?
Yes, thank you. It's David Mattiotto from the Mass Association of Behavioral Health Systems. And we had a lot of the problems from the inpatient behavioral health system early on with the PPE and staffing and new costs, and actually had a very big drop in census as well in April. Things seems to be roaring back now with census. We still have a lot of unused capacity because we have to have rooms for patients that are suspected of having the illness to be quarantined. So that's kind of exacerbated emergency department boarding. We're also having trouble discharging places, as many places are nervous about accepting patients without test results, et cetera. So it's put quite a strain on the behavioral health system, which is of course not used to dealing with such a contagious disease. So and a point on the telemedicine I want to just make quickly. I think I've talked to the insurers about this. There's really been some tremendous benefits for behavioral health in terms of one of the measurements our hospitals have is follow-up to care within 7 days of discharge. One of my large providers has been tracking this quite closely. They went from a 38% show rate to 93%. So 38% used to show up for their within 7 days. Now with telemedicine, it's 93%. So there's a real benefit there. We think it's really been helpful and hope it continues. Thank you.
Thanks, David. Okay, Dr. Dunlap's up next, and then Carlene Pavlos.
So I appreciate the advances in telehealth, but one of the things I'm concerned with is that the communities that already have issues with access, these are lower income communities, minority communities, may have that exacerbated not only by not having broadband, but not being able to afford it. That among the elderly, computer savvy is more limited. And so I think that we're making benefits on one end, but if you look at this across class and race, there are people who are falling behind.
Thanks so much for that. Carlene?
Dr. Dunlap just made my point, so I don't need to. Thank you.
Well, I think that's actually a really nice segue to the next topic that we wanted to preview with you today and to get your initial feedback on, which is around health equity and the importance of applying a health equity lens to all of the work that we do. So it's already been stated many times how important this issue is. And I would say while advancing health equity has always been an implicit component of the HPC's mission, the disparities within the Commonwealth and across the nation have called to light the need to make an explicit high priority effort of the Health Policy Commission. We know that these inequities are longstanding. They include differences in disease prevalence, access to services, quality of care and treatment practices and outcomes, including morbidity and mortality, among other things. And the COVID-19 pandemic has exposed even further the adverse circumstances facing communities of color, as Black, Indigenous people of color have contracted the illness and died at higher rates than those of white individuals. So we think this is a really important time and opportunity for the Health Policy Commission to make a statement and to be explicit about how we intend to advance health equity through our work. So we are preparing and developing a framework that we would plan to present to our board next week. And included within that is really making health equity kind of core to our mission. And we believe that it is, and being explicit is important. So one of the things that we'll be proposing, as you can see on the top of this slide, is our general mission statement, which we've had for many years at the HPC. And we would be proposing two changes to this. One, to include the word equitable in terms of the health system that we are seeking to advance. And the second change in blue here, which is one that we actually implemented a little bit of a year ago, is to be explicit that our goal is for all residents of the Commonwealth, again, trying to emphasize those points of equity. Our statute actually does charge the HPC with playing a role in healthcare disparities through its work. We actually have a requirement in our statute that the commission is intended to set goals to reduce healthcare disparities. Of course, this work needs to be done in very clear partnership and in alignment with the Office of Health Equity and the Department of Public Health. They are the leaders for the Commonwealth in these areas, but we believe the Health Policy Commission can support and include and advance those same goals through all of our work. And so what we're planning to do is to really put forth a framework to the board next week that would include, not shown here, but would include a statement of principles and values. It would include general questions, a quote unquote health equity lens that we would use to guide both the agency, the agency's work on all of our work, and to be explicit about ways in which our work streams will incorporate health equity And finally, an action plan to make sure that we follow through on this commitment. I would say this work is something that is being led by the entire Health Policy Commission agency. We've engaged in an effort to really have everyone's voice that works at the Health Policy Commission be a part of the development of this framework, and really want to thank the staff who have put so much time and effort into helping to develop this framework. And we believe the time is right for us to make this type of statement and to be explicit about how we will advance this work moving forward. Not just in, as I said, in relation to evaluating the COVID-19 impact, but really across all of our work. The next slide here, I won't walk through, but is just really an example of some of the materials that we're preparing. This is a kind of an example of a set of questions that we would be explicit about considering, as in this case, the development and implementation of a particular project. This could be a research project, this could be an investment program, this could be a market analysis. We think that these questions can and should apply to all aspects of our work. So I won't walk through this in detail, but just to give a sense of some of the ways that we're trying to be very clear about how we're going to pursue this agenda moving forward. So not more slides on this particular topic here today. As I mentioned, we do hope to engage our board next week and to seek their endorsement to be explicit about how we will adopt this health equity lens framework and action plan moving forward. But I will pause here and would love to get reactions and feedback to this approach and whether and any advice you may have for us as we continue to develop this framework.
Great. We've got Carlene Pavlos going first, David.
First of all, yay. David, to you and to all of your staff who worked on this, it's really, first of all, it's such an important statement at such an important time in our Commonwealth's history, in our nation's history, to be doing this. So I'm really grateful. And it's really clear that a huge amount of effort, I'm still like looking at this slide that's on our screen right now. It's clear that a lot of thought and a lot of effort has gone into planning this work. And I'm also really impressed and really grateful. I have a couple of sort of thoughts more than comments. One thought is, I love the idea of having principles. I think you also need some really clear definitions. And what I mean by that is, I think you need some really clear definitions about what, especially around race and racism. Because it's not because of race that there are inequities, it's because of racism that there are inequities in outcomes by race. And so we need to have definitions that help us understand that racism is not about feelings of individuals between each other, but is built into our structures and institutions. Of course, that's a lot harder. Once we recognize it, it's a lot harder to do something about that because it's so embedded in not only the ways we think, but in our practices and in our protocols and in our policies. And so I think that's got to be built into the definition so you are clear and other people are clear about just what it is you're trying to tackle. This is one of my calls would be that the HPC does take a racism first approach, or so not that it's the only inequity that you take a look at, but that you lead with a framework around racism, and then the intersectionality with other forms of oppression that also create negative health outcomes. And that's partly because of what we know about how embedded structural racism is within all of our systems, including public health and healthcare. It's also because we see such devastating inequities, and certainly COVID has laid those bear and exacerbated them. So I'd encourage you to consider that. And then the one other thing, just in the quick look at these 4 steps, is that one of your questions under step 2 in planning is whose voices are at the table and whose are not. I would encourage you again to think about a slightly different wording of that, which is to somehow embed in that the expectation that you will have the voices at the table of those most impacted. Right now, that's sort of neutral on whether there's a commitment for that to that. And from the vantage point of MPHA, that is absolutely central to being able to hold yourself accountable to the commitment to equity. It's something that we've only recently been explicit about. So this is more like helping you learn faster, because it took us a lot of mistakes to get to that point. And we had previously said, you know, who's at the table and who's not. And it really is, we are committed to holding ourselves accountable to the voices of the people most impacted. And then finally, I would also encourage you to say you'll have a written response to all of these questions as part of what's considered by the staff and by this body and by the advisory board as projects and policies are, you know, emerge for endorsement.
Thank you, Carlene, and I really appreciate your feedback and perspectives on this, and I may call on you offline because, you know, this is really important. Words matter, and we do intend and will be framing this in the context of embedded structural racism in our healthcare system. I think your comment on that last question is absolutely right. It feels neutral when it should be what is our intent there. And so, you know, for everyone on the advisory council, happy to take wordsmithing comments on these questions, but this is still very much a work in progress. So like, please give us feedback on this. But Carlene, I just want to say thank you for your encouragement and thank you for your leadership on this issue as well. And your organization's just supreme leadership. And that's, we're so pleased to be able to have you be a part of this. And I think you raised an interesting point, which is also how can the advisory council generally also play a role in helping the Health Policy Commission hold themselves to this and to be accountable to making sure that we actually follow through in the intent here. So I think there's a great opportunity for engagement with the advisory council on a move forward basis as well, and would welcome ideas about how we could best do that. I don't know, Carlene, if you had something quickly to add.
I do. Can I just say one other thing? Mm-hmm. So one of the reasons that I think that it's so important that you're taking this step right now is that the COVID pandemic has been truly horrifying, right? We've lost 8,300 people just in this state to COVID, and it has disproportionately impacted people of color. And at the same time, our country and our state is experiencing this emergence, especially for white people, of an awareness of structural racism. And I'm saying that as a preface to what I'm about to say, because there's a lot of pain embedded in those two public health crises that are happening at the same time. And to squander this opportunity that it presents for us to make real systemic change would, to me, be unforgivable. So I think that's one of the reasons it's such a perfect time. And I would also just add that it's not going to be easy. It's not going to be a unidirectional success towards change and equity. There's going to be pushback, there's going to be backlash, and there's going to be a sense that it's too hard. And if we could just get things back to normal and then deal with equity, that would be so much easier. The problem is normal is racist and unequal, and we cannot return to normal. And then we need to center equity, not marginalize it in our plans for recovery and our plans for change. So it's a really exciting opportunity. And it's going to be hard, and MPHA I offer our support and assistance if we can do that. And we also have a task force, an equity task force that has almost 100 organizational members. And I know many of them will also be really interested in this work. And many of them would be good collaborators as you take 2 steps forward and 1 step back and then try again, and all kinds of punctuated equilibrium in this work.
Thank you so much, Carlene. Okay, Dr. Cheryl Clark, please.
Hi, good afternoon, David, and to the group. I just want to thank you, David. It's been fantastic watching you lead on this and seeing you put this important frame forward. And I just want to build, I think, on Carlene's comments. As I look at the language and look at the framing here, I also think that we can be bolder here and make the anti-racism frame more pronounced. Increasing our language around eliminating these inequities, and we can do some wordsmithing around it. But I think the one opportunity here is to also think about how we push this as an imperative and to make it extremely concrete. Equity, as Carlene has mentioned, has been a nice to do. After we get everything else in place, then let's look and do some charts and see, what things look like by demographics. And let's put a committee together to X, Y, and Z. I think what we really are looking at here is, using the core function of HPC to provide guidance, to provide carrots, and quite frankly, sticks, to think about how we can hold ourselves accountable and being extremely concrete about it. We have to meet a benchmark of X% growth. That's a very concrete guideline or a concrete benchmark, right, that people can get behind. We have to think about what these specific concrete measures are that we'd like to hold ourselves accountable to around providing equitable care. As you know, I'm a physician. I took care of patients in the COVID unit. The word Carlene used is horrifying. It was to not have, for example, some of the equipment that we needed to speak in the appropriate language with our patients. How do we think really clearly about making sure that we have staff, interpreters, that we have equipment like tablets to be able to speak with our patients, and that when we have telehealth visits, for example, in my institution, some of our consultants had to call in, and our technology did not allow the consultants to call in virtually and see the patient and use an interpreter. So some of our non-English speaking patients could not access subspecialty care as easily because the technology wasn't there. So there are some specific concrete suggestions and guidelines that could be put to bear. And the question is, how do we use the core functions of HPC to embed this and to use those carrots and sticks? An important part of responding and being able to eliminate and to have an anti-racism frame also means that we have to collect information. And Massachusetts, was not as far ahead in some ways as even Cook County and other places around the country in being able to operationalize our data infrastructure and know what was happening around the epidemic. A lot of us found out about some of this because the press started making inquiries and asking to pull the numbers, and that's how we got some of the imperative to do it. And so as much as possible, making sure that we are investing in the trans or cross-institutional partnerships needed to get more data, and particularly data on race, ethnicity, data on preferred language, data on disability, and many institutions now have data on sexual orientation and gender identity. So making sure that we are really thoughtful and comprehensive in the way that we are looking at information so that we can see when the new peaks happen. 2 additional points. One is that another part of our imperative is making sure that we reimagine care. So it's not getting back to normal, it's reimagining what normal is. in order to provide care, we had to take care, as Jim Hunt says, out of even some of our buildings and structures into our neighborhoods. In Boston, that meant going into Hyde Park, into Dorchester and other places to actually provide testing there, and to build partnerships with community institutions to provide food, to get food delivery to folks who needed to shelter in place. So this idea around what new normal looks like is really real now. Incorporating social determinants of health is not a nice to do, it's an imperative. And so we need to think about what that looks like as we figure out what our care structures look like and how we want to pay for these imperatives. And then finally, we also need to think about healthcare as an employer. So far, I appreciated seeing the data early in the slides that shows that healthcare unemployment is sort of lagged behind other industries, but I fear that we've only seen the beginning of what this would look like. And, as we think about, what the pressures are, and looking at an anti-racism frame, a lot of brown and black essential workers, I think will be facing a lot of uncertainty in terms of what the future looks like. And so I think we need to incorporate the role of healthcare as providing care, but also employment as we look at what the future holds and how to think about what the business of care looks like. So I'm really excited to work with you on this data, David, and just sort of, think about how to frame some of this. But my largest recommendation is just to make sure that we take this opportunity to use all of our levers to make this an imperative, and not to go back to business as usual.
Thank you, Dr. Clark. And I think we as an agency and every member of the staff see that opportunity and are really energized about being able to take advantage of it. And so look forward to your great input and insights as we shape this language and shape the framing of this. And as Carlene said, we may not get it perfectly right the first time, but it's an evolution, and we look forward to really being explicit about the imperative here. So thank you for that. Colleen?
Sorry, I'm going to swing over to Dr. Dunlap.
David, I welcome this initiative. One of the concerns I have is that, in the next 3 or 4 months, we're not going to be able to eliminate racism, but we already know that there are communities that were much more heavily impacted by this. So I think that part of this is going to have to be getting some information from the ground up from those communities to look at how we can be more effective in this either second, or some people want to call it a third peak, because I think the impact will be greater because of the unemployment and so on, and the expansion and explosion in Medicaid and underinsured, that what we saw this time may only be the tip of the iceberg for the next go round. So I think some immediate goals in terms of crunching that data and looking at what we can do to course correct for the near term to minimize that impact is something that we really need to focus on.
Thank you so much, Dr. Dunlap. Okay, I've got Colin Killick, Dr. Wagner, and then Alex Sheff.
Thank you so much. First off, I want to echo all the comments that have been made, particularly both by Carlene and by Dr. Clark. Couldn't agree more about the need for an explicit anti-discriminatory approach, the need to incorporate social determinants of health. I would just add that it's wonderful and vital to adopt ethical principles. It's also vital that actual policies, including and even especially those that seem technical, be evaluated through that lens. I think we saw that here with the state adopting crisis standards of care that contain some moving and I think entirely genuine language about equity, and then adopted policies which were found by federal regulators to violate anti-discrimination law. And I think that can happen when the actual policy mechanisms aren't evaluated through the lens of those equity principles, right? If those are simply things that are written down and everyone says, yes, I will try to, incorporate those into my being. So I think that it's critical we evaluate there. I think it's critical that we make explicit commitments to things like the notion that the lives of all residents are equally valuable. I think is critical. We've seen, the tragic case a couple of weeks ago of Michael Hickson in Texas, so a Black disabled man who was deliberately denied a ventilator and nutrition and allowed to die by a hospital in Texas because in their judgment, him being quadriplegic meant that his quality of life would not be sufficiently high for his life to be worth saving. And I think that that is precisely the kind of thing we have to avoid here in Massachusetts. And I think that requires that these principles not merely be adopted, but be deeply integrated into all aspects of the HPC's work.
Thank you so much, Colin. Okay, Dr. Wagner and Alex Sheff. I know we're a little over time, but if folks can just hang out with us.
Just make a couple of brief comments. One is I was one of the co-chairs for the crisis standards, and I appreciate all the comments and the commitment that was made when the second version of the crisis standards were published was that the state was committed to work such as you're doing, David, with the HPC to address the issues of systemic racism. But I just wonder whether we're not really going far enough in terms of the concepts of white privilege that have been issues in the way resources in healthcare have been applied. And specifically, are resources going to be applied to hospitals that are caring for more communities of color and more underserved communities? The way that the pricing structure has been set up, and as you know, David, I'll get into pricing disparities, but just a glaring issue is that the hospitals that are predominantly taking care of probably more white patients and more patients who are privileged are getting paid more money on a per case basis than communities that have hospitals that are in poor communities and communities of color. So a very specific outcome of all of this work should be the appropriate and equitable application of resources to address issues not only of systemic racism, but also of white privilege.
Thank you so much. Alex, do you want to bring us home?
Sure. So this is Alex Sheff from Healthcare for All. I'm sitting for Amy Rosenthal. I'll make this brief because I think a lot of these comments have now been sort of mentioned. I particularly want to echo Dr. Cheryl Clark and Carlene's comments and Colin's. So I think 4 very quick points. The first is just, and I think Dr. Clark used the word bold. I'm going to use the word big, but I think I encourage HPC to just think as big as possible in terms of meeting the scale of this. So anytime there's a decision to go like big or to go slightly smaller than big, go big. The second thing I'll say is, I think that's really about meeting, thinking of this with a level of urgency that this moment calls for. I think several folks have spoken to that. So, I keep going back to and thinking about like how fast the world shifted on telemedicine so quickly, right? When there was suddenly like a will and a necessity that everybody agreed to do something, right? I mean, we saw things, happen in 2 months that people thought would take 20 years. And I think it speaks to the idea that if we commit to this work, a lot can be done very quickly, and we shouldn't sort of take slow and steady as the way it has to be. Third, or fourth, really, and I'll just end on this. I think just focusing on that last point, sort of closeout, and other folks have said this as well. Just being explicit about sort of policy changes and the direct action that needs to change, because in the end, this is really about shifting. Frankly, financial resources in a direction in a variety of ways across a lot of different sort of avenues. But those are things that can be done very specifically. You can put numbers to them, as other folks have mentioned, right? So I think thinking about that, and just 2 areas I'll mention within that, social determinants of health. I know HPC is doing a lot of work in this area, but like what we're looking at in terms of housing at this moment, the fear of sort of a potential avalanche of evictions. There's a study that's getting a lot of attention suggesting, 70% of those evictions could be in communities of color, and that's what we've seen historically. What does that mean? I know folks are thinking a lot about this, but what do we need to be thinking about in terms of continuing an eviction and foreclosure moratorium, supporting small landlords, increasing, RAFT and IRMA funding. And so thinking about those things. And, again, speaking to the urgency, like right now we are, there are decisions being made about how to prioritize limited access to asymptomatic testing, right? And where what communities to focus on. There's a very active conversation. The 8 communities being proposed, I think is like a great, first step, but more needs to be done. And so I think thinking about sort of how quickly some of these decisions that really determine how equitable our COVID response are being made right now. So I'll end there. Thank you, and thanks for giving me the moment to speak.
Thanks so much, Alex. David, back to you.
Great. Well, thank you all for the comments and words of encouragement to think big, think bold, to reimagine care, as Dr. Clark said, and stretch the bounds of our imagination for what that could be. So we will take these words of encouragement to heart as we continue to prepare this framework for discussion with our board next week. And beyond. Again, we don't view this as a one-off thing that we put some slides up, have a discussion, and walk away from. This is a commitment, a deeply felt commitment from everyone at the agency. I won't go through the rest of the slides. As always, I will leave those for you to review on your own. The second part of this presentation just talks through some of the priority areas that we are considering for the rest of the calendar year in terms of our explicit agenda around COVID-19. Really thinking about evaluating the impact, as we've already discussed, on providers, health plans, consumers, employers, evaluating the impact of the policy changes like telehealth and out-of-network and scope of practice that occurred during the pandemic, thinking about system capacity planning, both in the short term and in the long term, and also around using our investment programs and certification programs to continue to advance transformative care that we think is, as Alex, as you said, an opportunity to move things forward at warp speed in this particular environment. So feel free, please always reach out to us if you have additional thoughts on those slides and on that agenda. I think we will probably be back at our next advisory council meeting, reviewing many of the same topics and giving you updates along the way. And I expect that we will be calling on many of you to help us with this work, because it won't just be the HPC. This is going to be work that spans multiple agencies, public and private, and look forward to working with you all together to advance this really important agenda. Stuart, I don't know if you wanted to have any last words before we close out.
No, this was a great meeting. A lot of food for thought. Thank you so much. This was great.
All right. Well, thank you, Advisory Council members and members of the public. We will be in touch regarding the next meeting, and I hope that you all have a very nice week and rest of the summer. But look forward to hearing from you and from us often.
Thank you all.
Thanks, everyone. Have a great day.